Welcome to Tabad Lab's Policy Roundtable on the COVID-19 vaccination. And the question that we're asking is, when will Pakistan achieve herd immunity? My name is Amber Shamsi. I'm head of communications at Tabad Lab. Dr. Shabnam, who was representing the government, Dr. Shabnam Sarfaraz. She's at Harvard. She could not join us because she had another meeting, but that doesn't mean that it doesn't take away from the panel itself. We had Dr. Rana Asghar, who's the CEO of Global Health Strategists and Implementers, Dr. Adeel Ajwad, who's a professor of medicine and professor of population health at Cornell, Dr. Muhammad Ali Chaudhry, who's the founder and CEO of Emerging Health. Thank you so much for giving us time. I sort of begin with the COVID-19 vaccination is not being equitably distributed across the world. So 14% of the world's richest country, 14% of the world's population, the richest countries, have secured about 53% of the COVID-19 vaccine. Meanwhile, in Pakistan, the vaccination drive has begun. Vaccine. We were waiting for the COVAX facility vaccine, which is AstraZeneca, sometime in March yet. But at least the vaccination drive is beginning and has begun, and awareness campaigns have also begun as well. I'd like to begin with Dr. Bhatt first. And if you could talk about herd immunity, one of the ways that we achieve it is obviously through infections, but the other way is through vaccination. Be able to your comments on this. I mean, because herd immunity, some people say it's a myth, some people say that it could potentially be achieved through these two things.
Assalamu alaikum. I lost part of the question, but I think I got the gist of it, so I will try to answer, and if I miss something, please let me know. Mm-hmm. So I think the first thing to do is clarify the concept of herd immunity. What actually is herd immunity? People think that herd immunity means that suddenly, all of a sudden, one day you wake up and the population will be immune to infection that is going on in and around you. That is not the concept of herd immunity. The meaning of herd immunity is that if there are a large number of people who are either infected or protected from infection, whether through vaccination or natural infection, the remaining small number of people will not be exposed to a lot of infected persons. So they're less likely to get that infection. And that is a number, if you achieve that certain number, then the number of infections or the rate of infection in the remaining population goes down very significantly. And that level is known as herd immunity. Now, from a scientific and epidemiologic point of view, herd immunity is a very simple mathematical principle. So herd immunity is directly related to what we call R0, R0, which is a measure of infectiousness of the virus. And you measure R0 by three factors. So three factors determine R0. And those three factors are: one, infectiousness of the virus, yani ki virus kitna infectious hai. Number two is the number of vulnerable people in the population. In other words, those who have not been infected or not been vaccinated. And third is the duration of contact that these people have. So any three of these factors, when they go up, your number to or the proportion of persons to achieve herd immunity goes up. So in other words, these three factors, if you can affect them somehow, you can bring that number down, the number that is required for herd immunity. To give you an example, infectiousness of the virus is dependent on the virus strain. For example, the original strain was infectious at a certain level, but the new strains that we've got in the UK strain, the South Africa strain, and the Brazilian strain are much more infectious than the original strain. So that number has gone up, meaning compared to about 6 months ago, now the level of population that needs to be immunized or protected is much higher to reach the herd immunity level. The second factor is the available vulnerable population. And that means the persons who, again, are not infected. So you can increase that number by vaccinating people at a large scale. So you can directly affect all these three factors. The third factor is the exposure time, which can be reduced by having these physical distancing measures, wearing a mask, and so forth. So अब अगर आप देखेंगे पिछले 2 से 3 महीने में क्या change आया है, वो change ये आया कि we have, at least in the rest of the world, in many countries, a much higher infectious virus strain. The UK strain is about 65% more infectious than the original strain. The vulnerable population is starting to go down by vaccination and by natural infection. However, the third factor which we can impact is reducing the time of exposure of people who are vulnerable by masking, by social distancing, and so forth. Agar virus ka R naught is about approximately 2, in other words, if one person who's infected infects 2 other people on average, the herd immunity level required is about 50% or so by a simple formula, which is 1 minus 1 over R naught. If that number goes up, if R naught goes up to, say, for example, 3, the herd immunity level required is 66.6% by that simple formula. If it goes up to 5, then 80% of the population needs to be immune one way or another to reach that herd immunity level. So this is the brief concept of herd immunity. Pakistan mein kab, when we will reach that, I think that is left to, I think my other panelists are much more knowledgeable about the situation in Pakistan. We look at the data from a little far away, sitting in the US and Qatar, although we do have reasonably good handle talking with the government officials, but probably other people will be able to tell us much better at what those 3 numbers are in Pakistan at this point in time, for particularly R naught.
I'm going to turn to Dr. What percentage of the population needs to be either obviously vaccinated or have be infected in order to have herd immunity? And then obviously the secondary question here is we're now in the middle of the 3rd wave, and it has been acknowledged by government officials that the UK strain is Dr. Rana.
Thank you, Hamad, for inviting me with this distinguished panel group of experts. So I will take some, what you have been told right now is very correct according to epidemiology. And when this pandemic started in Pakistan, I was part of the, I was, a part of the first core group which started working or advising government on how to manage this pandemic. And I remember in those early days, like we still didn't have a case in Pakistan, but people were very worried. And everyone was talking about R naught and capital N, like a new disease when it comes, what is the maximum number of people it can infect in Pakistan? And that was a worrisome question. So I was part of a small but very high level meeting by a sensitive organization where everyone was worried and asking this question. And I was the only epidemiologist there. So I told them, which I'm telling you now, that R naught or what is the ideal number of herd immunity, they are not set in stone. Let's talk about R naught or capital N. Like we can influence it by many things, by our non-pharmacological approaches, like this masking, social distancing, and if you bring that in a population, your R naught will go down, irrespective of it's the same virus or it's a more lethal virus. Similarly, the N capital is also affected by how your control measures are effective or not. Herd immunity is also used in early phase, at least from the non-technical side, because that was the ultimate goal. Let's try to figure out how many people have already been infected in Lahore, and maybe everyone, 50 or 60% of people have already been infected in Lahore or Islamabad or anywhere, so we should not be worried. So when government officials move toward herd immunity and acquiring that herd immunity in a phase of pandemic, that shows they don't have a strategy, and actually they don't have any control measure, and they don't want to invest in the public health processes which are required. So there were studies which were done both in Lahore, Islamabad, and other places. And there's forget about their design issues, but even their results were not encouraging. Very early in the pandemic, we knew that pursuing herd immunity by natural infection is actually a suicidal trap. And how we figured that out? Very early in the pandemic, we knew that in the boroughs of New York, which were devastated by coronavirus, um, once they did the seroprevalence surveys, and also in those counties or districts of Italy, which were really badly affected by coronavirus, there was hardly the maximum number of positive in community was around 19 to 20%. And just today, Lancet has published a paper about the Wuhan and their seroprevalence surveys by the end of April. And you remember, by the end of April, Wuhan was already out of their main outbreak, and even the city most affected of this outbreak, the prevalence was I think 19% or so. So, so, and now the latest information we got from Brazil, one of their cities, which seroprevalence surveys told that 70% have been already affected, and they had so many deaths happening in the first wave that the government didn't have places to store those bodies, and they were littering on the streets. I'm sure all of you have seen. Now they got another peak. So thinking about it doesn't matter it's 60%, 70%, and 80%. Um, just getting herd immunity through a natural infection is a very long process and very dangerous process. And on the vaccination, when we will come back on the vaccination issue, that's that part that we will acquire that immunity through vaccination seems a very long way to go still. I will stop here so others can join me.
Okay, brilliant. Thank you so much, Dr. Rana. And Dr. Rana you've obviously talked about herd immunity and how it's unrealistic and given fatalities and mortality. And you gave the example of Brazil as well. But I want to talk about vaccination. Distribution of all issues that have been talked up. I mean, because there was a lot of celebration when the vaccines were approved and shown to be working against the virus, but something seems to have fallen by the wayside in terms of distribution. We've seen a lot of squabbling between the EU and the UK, for instance, on AstraZeneca. We've also seen gifts and charity being done as part of a vaccine diplomacy. The COVAX facility has talked about supplying 20% of rich countries are hoarding the vaccines. So, for instance, Canada has secured enough vaccines of its citizens 5 times doses. And yet in Pakistan and other countries, including Afghanistan, for instance, and I was doing comparison of the figures, we are still way behind. For every, just looking at the figures, for every 100 persons, Pakistan is, and I'm just opening the data so I don't get this wrong, Pakistan is 0.16 dose of the COVID-19 vaccine. If you can hear me, Dr. Chaudhry, I could always repeat the question as well. Perhaps your mic is on mute.
Sorry, I said you dropped off, so I couldn't hear the question. If you don't mind repeating or sending a message, then I can reply. I heard
shorter
parts of
version
the
of it.
Yeah. I can't hear it.
Can you still hear me? Can you hear me?
Now I can hear you, yes.
Okay, great. So richer countries were estimating that they would reach their target populations, the most vulnerable, by March. We are in March. some by June or July. And yet we see middle-income countries and poor countries left by the wayside. And one of the questions being asked is, should there have been a global response in order to ensure
So I lost the last part, but in terms of understanding the question, the disparity that is becoming apparent between the developed countries and the developing or the emerging countries is a challenge that we are now facing and will be an ongoing challenge, and that's the question. So first of all, thank you for inviting me and with such an esteemed panel. I would pick up and answer this question from a few of the things that Dr. Jawad and Dr. Adeel has said. That first of all, this concept of herd immunity as some sort of a panacea for addressing this issue and somehow the disease will go away, it's a wrong promise to make. And that's where we are compounding the problem of disparity, not just between the developed and the developing, but among the developing as well, somehow that you get the vaccine and this will be over. It's not going to be over. The influenza has not gone over in 100 years. So how is this going to be over? This is not going to be over. So we need to address in-country disparity as well before we talk about the disparity within the Western world and the developing countries. That's one thing. Secondly, the disparity as it is going on is the same problem which we had started to talk about, where because of the globalization, the diseases that are emerging or are going to emerge will be very different than what we are used to and the systems that have been built. So that is the second problem that we are going to face, and we are facing now on an expedited manner, where what we are seeing is that the Western world is using the resources to vaccinate their own population, and they will continue to iterate those vaccinations for new strains that are going to come. Because this is, again, not something that's going to go away in March or June or July or end of this year. This is something we'll normalize or live with for the foreseeable future. So that is going to happen, and that's where the middle countries, the low-income countries, the emerging markets, they have to really think about where they should be focusing all their resources. And this is the time when they get into these conversations with the developed countries. So instead of keep asking for grants and donations and loans to give vaccine, which is never going to solve your problem, because of a very simple fact that majority of your population does not live in urban areas, and you are still vaccinating only the urban areas. It's not going to go away like this, and we have this disparity that's going to be prevalent. So strengthening your basic health system is the opportunity to expedite that process. This is the opportunity to work with these countries and develop an equitable model to develop these vaccines or the future of these vaccines in your own countries at some point. Because if we do not build an infrastructure, the Western world is going to move on at some point, because they are vaccinating their people and they will continue to vaccinate. But we will be left with this issue of we can't do much about you. And we have seen in the past, and we have experts in the room that have a lot more knowledge about this, that there are certain diseases that we were left with and we still deal with them. Malaria being an example, TB being an example that we still deal with, but it's no longer a Western problem. So this is the same thing that we're seeing again is happening. The vaccination is not equitably distributed, and promises are made in somehow that if you vaccinate X amount, the governments in these developing countries are left to run after this abstract number to bring more and more vaccines whichever way they can and try to reach a milestone which does not exist at the point. So it's a multifaceted issue that we need to realize and work with the Western world and among ourselves as well, and set our priorities, what we need to do for the long term, because this is not a problem that's going away.
All right, thank you, Dr. E. And I think that's really important, and I will come back to that point, but I want to sort of move on to Aisha Raza Farooq as well, because let's talk about the vaccination campaign that's happened so far in Pakistan. We have had healthcare workers, that includes lady health workers, nurses, as well as doctors. vaccinated yet. Moving on, we have the elderly. That vaccination drive has also begun. An awareness campaign has been begun by the government as well. We saw the Prime Minister getting vaccinated yesterday. And yet we still don't have quite as much data on the progress, or we don't know how this vaccination drive is being tracked. And I can repeat the question because I'm really asking about, we had the infrastructure. I mean, you led the polio campaign successfully in your term, focal person on polio. That is a similar kind of infrastructure that's expanded and used for the vaccination drive in Pakistan as well. How do you see it progressing?
Thank you, Amber, for inviting me for a very critical discussion on COVID vaccination, its equitable distribution, procurement, and related issues. I think, first of all, if I were to describe Pakistan's response to COVID, and especially its planning for COVID vaccination, I'd say I do three words. One is confusion, mistrust, and inconsistency here. One, we've repeatedly heard our ministers and spokespersons for the government throwing different names of vaccines to us, with no clear timelines or quantities, building unrealistic expectations out there amongst the population. So you see, apart from the few 1 million so far that we've had as a gift from China, and what is promised through the COVAX facility, that amounts to less than 0.5% of our population, and primarily in our urban areas. The uptake for vaccine is very slow also. So learning from the polio program, I think, where there are many lessons to be learned here, I think as far as overcoming vaccine hesitancy and planning better using existing polio structures and assets is concerned, we could have used the emergency operation centers, which was used to some extent, but more so for surveillance purposes, for early detection of the virus, and then timely response wherever you detected the virus around the country. And for vaccines specifically, I think an ample groundwork was not done in building trust between the vaccine and the caregivers over here. Like we did for the polio campaign, I think you need very clear, consistent, transparent messaging here, using influencers and religious or political leaders who can create that trust depending on where you're advertising. You have to bear in mind, Pakistan is very diverse. It's diverse geographically, in terms of ethnicity, in terms of language, in terms of culture, and one message may not and has not seemed to work for the polio program as well. And you need different messaging in local languages across. While we've seen the Prime Minister being vaccinated fairly recently only, I wish that had been done much earlier, because despite the very small quantity of vaccine that's been made available in Pakistan, the slow uptake is not encouraging at all. And our health workers themselves are refusing vaccination. And that does not add to the atmosphere of trust, transparency that you would like to see out there. And building on what has already been said by experts, epidemiologists, and public health specialists here, if you're wanting to increase improve health equity or build herd immunity, doesn't only come from vaccination out there. There's so many other things that you can improve on the ground, which is the SOP regulations, in adhering to SOPs over here. And we again see very, very dismal steps being taken there, from complete denials on the one hand, to opening up areas and then closing again. There seems to be lack of vision. There's no clear strategy over here. So I mean, a really very, very confusing strategy, whether it's for vaccination or communication or otherwise, has really exposed the already weak health infrastructure that we had in the country, and the grave inequalities in health that existed beforehand have just exacerbated because of a pandemic, which may be here for a very, very long time.
Aisha, I'm going to move on to Dr. Adeel now, and picking up from the thread of all of this. I think what's also interesting is sort of you talked about data and sitting far away. of COVID-19. And I think learning the lessons from the first wave, that system is in place. But isn't it also important to have publicly available data tracking vaccinations as well? And what impact does that have on, for instance, which vaccines to purchase and which areas to target and which critical populations to target as well?
You're absolutely right. In our field, healthcare, epidemiology, and public health, the most important thing, the most important tool we have is accurate data. And we need to translate raw data into information, actionable, and information into actionable intelligence. And all that starts with having the raw data that you mentioned. How many people have infection? What type of infection? What are the demographics of the people? What are the behavioral patterns of the people who are getting infected, and so forth. And then, of course, the next stage is who is getting vaccinated and what the vaccine response has been in the real world setting. We know the result from clinical trials, and those are very reliable clinical trials that have been published by very reliable groups and with excellent methodology. But they may not always translate exactly into the real world settings as well. So all those data are critically needed to have a good, unified, country-level, national-level response to any pandemic or any public health emergency. And I will give you an example of a couple of countries who have done that very well. For example, Qatar has done it extremely well, and we have published several papers of how we used data and mathematical modeling to anticipate the next waves and the peaks of the pandemic, and put together public health measures which were tailored or graduated to the level of infection that we were seeing. So we do that on a regular basis. We meet weekly, sometimes several times a week, go over the data and so forth. And that has been critical in making sure that the case fatality rate, for example, has been one of the lowest in the world. From Pakistan, we do see a fair amount of data that is being shared. There is a website that has been created by the government of Pakistan, the National Health Commission, or the relevant agency. And it does have a fair amount of data. The veracity of the data, I do not know sitting outside because I don't look at the raw numbers and so forth. But when I look at it from a little further away, it seems that a reasonable amount of data is being produced and shared. Now, how is that being used to drive public health policy is an entirely different issue, and we can talk about that in the later segment. That with those available data, what are the things that we can do to have a data-driven response to the pandemic and have it and have it tailored to what is going on in almost real time in a country like Pakistan.
All right, and if vaccination data as well.
So could you repeat the question, because we lost that, and who was it directed to?
Yeah, it's directed to you, Dr. Adeel. Vaccination data. So, like I said, we acknowledge, and I acknowledge that the government has actually been, since the pandemic began, arrived, who is getting it, healthcare professionals, the elderly have begun getting vaccinated, but we don't know the numbers yet. And we're not entirely sure the target population and when that will be reached. So how has, taking the example of Qatar, have they also been publishing vaccination data, and how crucial is that? Just if you could speak to that briefly before I move on.
Absolutely. So we are publishing the data, but not all of those data need to be published for public consumption. So we have to separate two issues out here. One is the prioritization of certain groups. Now, the reason we are prioritizing is not because of anything else except the fact that we have limited supply of vaccine. If we had enough supply and we had logistic infrastructure in place, this issue would not be happening. So everyone would be vaccinated who was otherwise eligible for vaccination. So the reason we are prioritizing and we're putting targets is purely because of those non-medical reasons, and whichever algorithm you use. The fact when you do have vaccination data, again, like I just briefly mentioned, that the public is entitled to know that data, but it's not necessary that the public has access to every single data point, because they would not be able to make sense out of that. There are so many nuances on those data that actually it can be taken in the wrong way and has been taken incorrectly and by certain groups and manipulated for various reasons. But the public policy people who make policies must have those data at hand at all times to make those decisions. How many people have been vaccinated is critical in understanding, and also who has been vaccinated is critical in determining how do you carry on the rest of the campaign of vaccination. Who do you target next? Again, this is because we have limited supply, at least at this point in time, and we don't have the infrastructure in place to vaccinate everyone. Even countries who have a lot of vaccine have not been able to give that vaccine quickly out because the infrastructure is not in place. Take the example of the US, for example, or many other developed countries who did have the vaccine. The vaccines are lying in freezers somewhere, and they just can't get it out because there are not enough people to give it, not enough centers to give it. And you also mentioned Canada early on, and if I may get another few seconds to mention that. Mm-hmm. So Canada was a success story till it was not. So they did purchase 5 times the amount of vaccine that they needed. However, in their contracts, they forgot to put the delivery time of the vaccine. So they were one of the last ones to begin vaccinating people. So Canada is far behind any other country in terms of vaccinating the vulnerable population, because although the contracts were all signed for large amounts, the delivery time was so far down the road that they did not receive any vaccine till very recently, till about a few weeks ago. And they've just started vaccinating people. So that is another thing that policymakers need to be aware of, that you need to sit down and forecast some of those things, not just from healthcare professionals, but also procurement people, also logistics people, and so many other people need to be involved, as Ms. Aisha would point out, having run a very large national campaign, and others on the panel. I'll stop here.
All right, thank you so much. And I'm going to move on to Dr. Rana now and take that conversation forward. So we've seen, even with the COVID-19 response, the US, for instance, the UK, there were lockdowns again in Italy. So it isn't as if Pakistan is the only country in the world that's struggled. And in fact, we've seen developed countries really struggle with the pandemic. But we've also seen developed we also talk about, for instance, some of the fears around the vaccine. That in the polio in terms of blood clotting. And then there needed to be an approval. The campaign was suspended. Do you think that this happened far too quickly around the world for anyone or any country to cope with, in terms of not just the pandemic, but also the development of the vaccine and then its distribution and ensuring that citizens?
I think, I didn't get the whole question, but again, the gist of the question, which I understood was that the governments around the world's knee-jerk response and then shutting down the vaccination campaign. And but that was I think, the gist of the question. Yes. So yes, and you are right. And someone has to think over it, that why the country is so advanced around the globe failed so miserably in the pandemic when the pandemic came. And one common thing I can identify pretty much everywhere, in most of the countries, not everywhere, is that once the pandemic arrived, they decided the people who are infectious disease epidemiologists or all those kind of people are not the right people to advise governments. So governments started around the globe, started advising, getting advice from first was the mathematical models. And then second, it was anyone who has a political affiliation with them or personal contact with them. Just look at all those people who are advising in real matter to the senior decision makers around the globe. And each one's, if you go for each one's expert history, most of them have, and I would say most of them, have never ever managed a single outbreak. So people with no experience of managing a real outbreak in their whole life now are advising governments how to manage once in a century pandemic. So that was a structural issue, and why that happens, that's a long story. But now what's the problem? Why we have this knee-jerk phenomena? That's again because of the panic. As soon as I heard about, blood clotting issues of AstraZeneca, my first, question in my mind was, what is the background rate of blood clotting in that population? That was the simple measure I need to know before I can judge. And this could have been in those countries, in those Western countries. These numbers are handy, and someone could have just gone to the library, access some journal, and get that information. That, for example, in Italy, what is the journal occurrence or the rate of blood clotting in general population, and then you compare it with the population which has been vaccinated or unvaccinated, and see is it much higher than normal population. I am amazed that like 20 countries stopped vaccinating, because there was a panic and fear and the political cost countries were not ready to take. And the problem now will not finish by them now restarting their vaccine campaign, and most of them have already started that campaign. The thing is, when the news traveled to countries like Pakistan and all other countries where we already have, all the conspiracy theories about vaccines, it will be much harder to then convince the general public to go for a vaccination. So I think including Pakistan and including US and all the countries in between, the pandemic has been managed by most unscientifically way, by those who have no experience, actual experience of this. And one of my articles, I gave the example that it's like, we hired the journals to fight a word war who have never fired a bullet in their life. They may have been very well, distinguished scientists in their own field, but with no experience. That created panic, and every hick which come in the way, pretty much everyone gets worried, and then governments make decisions which are not accurate, scientifically accurate, and actually cause more harm than to protect the population they are supposed to protect. Thank you.
All right, thank you. Dr. Chaudhary, I'm going to move on to you now because Pakistan has allowed private companies to import the vaccine. There have been concerns about pricing, and I know I got a few questions on this as well. On the other hand, the government of Pakistan, naturally through the donations, Sinopharm, through China, I mean, allowing private companies and yet they will be able to get themselves vaccinated. Do you think that there needs to be a price cap? Do you think that this is one solution to the problem getting the vaccine into a country like Pakistan?
Sure. If I understand, again, the gist of the question, Amber, was about private sector's involvement and the pricing of taking such an exercise of letting them import vaccines and so forth. So look, again, we go back to the question of the private sector plays a critical role in Pakistan's healthcare delivery system at the moment. So allowing private sector to bring vaccine is another way for government to get help, to let the private sector contribute by bringing from different countries, from different areas, different vaccines that become available. So that's the first element of bringing the vaccine into the country and letting private sector do it. The second part of it is, which is around the pricing of it. As we know, that government has been controlling the drug prices and has been controlling all of this. But this is an emergency where even the private sector, provided that you are addressing their underlying issue of cost or cost plus margins, cap can be introduced for the segments of the society that are at the borderline. And that's where the programs that government has designed, whether through the Nadra database, whether through the Sehat Insaf cards, whether through the income support programs, let them get it if they can get their hands on. Because the government alone cannot deliver these vaccines to every person in the country. Private sector has to come in. Private sector can be partners in this and let them formulate a policy with you as well, that when they are bringing these vaccines, there are segments of the population in the country that can easily afford it at any price. So let's not benefit everyone the same way and say, look, cap the price and everyone buys it the same. We have mechanisms in place, not perfect, not ideal, not complete, but let's use those to bring those vaccines, to give it to the segments of the society that can afford to at different price levels as well. And private sector is very good at this. Let's not forget that the private sector is already doing that for services that get offered between a village and Lahore as an urban metropolis. We're still delivering different types of services, same surgery is getting done at different price points. So private sector has a role to play, but the government has to get over this, the skepticism of the private sector, despite the fact that they are the main delivery system in the country, and let them be a part of it. Because otherwise government can import how much? We have seen it, that so far with all that has come in, we're talking about 1% of the population. What about the 99? How are you going to get that? There is no strategy, there's no path forward that can be shown that the government alone can do it.
Okay, governments alone obviously can't.
It's patchy, but I can't hear you, sorry.
Yeah, I'm going to switch off my video for
Sure.
repeating it. Aisha, I'm going to move on to you because I want to also talk about vaccine diplomacy and nationalism. And I think it's interesting where we were told initially that the AstraZeneca vaccine would be arriving sometime in March. It hasn't yet. We're still dependent on donations from China, which is great, all-weather friend. But there were stories, obviously, that the AstraZeneca vaccine was being manufactured, and we know had been back to awareness. This goes back to some of the problems that we've seen in the polio campaign as well. If a vaccine is thought of to be made in India, it could be a problem in terms of getting people to get themselves vaccinated. So what do you think is a solution then?
But this brings us really to the question of building primarily a political consensus and popular support around issues like polio or like the COVID vaccine. If one has done that and you've engaged properly with all stakeholders, which is the religious leaders, the religious lobby here, pediatrician doctors, political parties, political leaders, then such questions of where the vaccine is being manufactured, should we be importing from a country which is in your country, the name itself is going to invite a lot of misconception and conspiracies attached to it. And that's one reason we avoided importing the polio vaccine also from our neighboring country, India. But we had ample supply from other countries. So I think to build consensus, to make sure you overcome that particular hurdle from a diplomacy point of view is important. Two, I think building on ideas that have been raised here, I think I'm a little disappointed where the government's made tall claims of putting aside funds for the COVID vaccination drive. We do not see to date any disbursements made here. So if there are any spare money funds lying on the side, I think this is an emergency right now, and all funds should be diverted to try. If the private sector can import the vaccine, why can't the government use its own funds to import vaccine right away? And while I agree that we should allow the private sector to come in here, I also worry about inclusivity here and health and equitable vaccination over here. What percentage of the population can spend that kind of money to vaccinate themselves? And then let's also think about that large majority of your population who cannot spend that kind of money. Even if the government caps the price at a certain level, the government has to step in and step up its procurement policy and strategy over here. Otherwise, you see what we saw with testing here, with each COVID test, and the private labs charging a very high amounts, first 10,000 per test, and then they reduced it to something like 6,500. The reason we had low testing was the pricing here. I saw a lot of my domestic staff suffering from flu and fever, but they couldn't afford it till we sent them to private labs to get their tests done. So I do think there should be no denial here when we say that there is low uptake. One, yes, because of the conspiracy theories and the misconceptions around vaccines traditionally in our country, but also because of affordability. And that's a huge worry for me, really, as someone who's led the polio campaign and looked at and talked about and implemented equitable vaccines all over the country. I'm, for one, very, very worried about equity when it comes to COVID vaccine, and letting the private sector here get absolutely a free hand in deciding the pricing too.
All right, valid points. If you can hear me, I think there's because Dr. Rana, I want to turn to you as well. Continue my question. Vaccination is now taking place in urban areas. Does that mean that COVID-19 and vaccination is purely an urban problem?
I didn't get the whole question, but let's talk about the vaccination challenge in Pakistan at this moment. Just think about how much we got vaccine until now. That's a 500,000 we got from China. And just yesterday we got another 500,000. Out of those 500,000, how many have been used is a major question in last 4 weeks. And according to the WHO data, it's very few. But let's assume all 500,000 have been utilized in 4 weeks, and we will get some more from the COVAX deal. But our vulnerable population in Pakistan, which is above 65 years old, is around 8 million of those. And until now, we have got, used or applied less than 500,000 vaccine. So that's why I'm raising the question that as soon, even if you, and Madam Aisha can tell this very well, even if you get the vaccine, you need to have a very robust system of ensuring the cold chains, your vaccination center, how you are going to implement this. And this is an emergency, but I just saw a notice, a government notification, just like a few minutes ago, that they have said that all the vaccination centers will not work on Sundays or any holidays, and they will just work on the regular days, even though the hospitals are open 24 hours a day. So that shows, the point I'm raising is, that shows the hodgepodge approach to health crisis situation, which has come to us after 100 years. We are not realizing how big this is and how properly, and I agree with Madam Aisha, that our approach to this COVID-19 has been of a confusion, late steps, and not relying on your own data. Your data may be bad or whatever, but you should make your decision based on the data you are collecting, and that's create a problem, which I'm raising it again, that procurement and then deployment, then risk communication, ensuring that you can control the vaccine hesitancy or decrease it. These are such a tall orders. I don't see at this moment anyone addressing those in a proper way. So I'm very disappointed, or let's say on the vaccine, to get herd immunity through vaccine in a short time period. So I will, it's the last part of the program. I will, again stress, use, wear masks, keep social distance, and open your windows.
Saying that's what I understood from it. Dr. Chaudhary, we are at the last sort of a part of this panel discussion, and I know you, at the beginning, you also talked about a response that is globally coordinated. If you could speak to that, and perhaps also respond to Ms. Aisha Raza Farooq's comments about the private sector.
So thank you. And the comment the honorable senator made about the private sector and your question on global coordination. So absolutely, the first thing is global coordination, because not just in vaccination, but every aspect of this disease management has to be part of it. We have talked about globalization of everything else except healthcare expertise, the ability to move around. We have not been able to move physicians out of different places. We have not been able to coordinate with expertise that have had more cases to deal with and had the expertise to at their hands, that the knowledge could have transferred to other places and have a coordinated approach, because it's, again, not just the issue of vaccination, but the issue of treating it as well. And then the vaccination in terms of what is the numbers, and sharing data among each country, and have, even if it's model based, have some sense of reality, that what we can do and what we are going to do, to set an expectation which percolates down to different socio-economic and socio-political perceptions about what the success would look like and where we're going with the disease. The second aspect of the private sector and the pricing and so forth. Private sector participation does not mean it. Again, that's what I mean by skepticism. Private sector brings in a certain level of efficiency into the system. We know it from examples of all the PPPs and everything that has been done with variable level of success, but it is inherent in the DNA of a private sector or the government bureaucracy. So we need to look at where private sector can contribute. Do not look at them as just as another entity that the government has to control or anything. Bring them as partners and work with and share what you need to achieve and help them achieve it as well. Pricing is just one mechanism. Communication is another channel. Addressing, they have a lot more better understanding of how people make decisions across different segments of the society and different geographies. So use them to understand what people are thinking, so you can deliver focused messages to those people and address those concerns of vaccination that people are very prevalent.
I'm going to, while I was reading up on this, I found that South Africa, the cost of the AstraZeneca, the price of the AstraZeneca vaccine is at least 2.5 times, for example. So could you sort of, could you talk about that as well? So AstraZeneca.
Sorry, I couldn't hear the question.
If I could repeat the question. A lot of questions, and the question here is, as an example, South Africa, the AstraZeneca vaccine is available at 2.5 times the price it is in the European Union.
So if I understand the pricing difference between a Western country and an African country, albeit South Africa for that reason, again, this is not a new phenomenon. We have seen it. For example, HIV is a classic example of disparity in prices that were introduced positively, because the same HIV treatment was thousands of dollars in the States, but they were offered for $1,000 or $1,200 in Africa and India and other places. So we've had those mechanisms, but it happened because there was a coordinated approach and understanding and aligning the realities on the ground in terms of what people are able to afford and still be able to provide them. Because this aspect of charity and grants and loan are going to run out at some point. And then what are you going to do? So my question, which the topic started with, the political economy, and what I'm worried about is the economic crisis that is building up, that once this all runs out, we will never be able to reach 220 million people. What are we going to do? This is the time where we need to reprioritize our resources and look at the mid and long term as well by developing facilities. However primitive they may be, they are something that we can own and develop and enhance over time. But creating a promise that somehow, if we were able to get our hands on 220 million vaccines, this is going to address the issue, it's an elusive dream. Sorry, can't hear you. I'm sorry.
All right. If you could hear me, Dr. Adeel.
Yeah.
All right. Okay. So my final question, we also got UAE, where the population is much. Look at the data, easier to manage the pandemic and the vaccination drive as well. If you could answer that question, and also using remarks, because I mean the fundamental question we were asking was when will Pakistan reach herd immunity, which may seem unrealistic at this point, but I think that is at least we can think about perhaps coverage of 50% of the population.
So I lost most of it, but I think if I understood you correctly, there's a question about differences in small countries versus large countries like Pakistan, both in terms of population and geography and area. And the second part was a closing remarks about the level of herd immunity. So I fully agree that it's easier to do things in smaller countries where you have a much smaller population as compared to Pakistan. But that goes back to the points that everyone else made earlier. Dr. Asghar, Dr. Chaudhry, and Ms. Aisha, all of them made the same point that we have to have infrastructure in place, not in a reactive manner, but in a proactive manner. This is a wake-up call for us to have all those sentinel sites and infrastructure of data gathering in place that when the next pandemic hits, and believe me, it's a matter of when, not a matter of if. When the next pandemic hits, we are ready to go on day one, gathering data and making all these decisions that we are making right now in countries which have much better data systems. So on one hand, yes, larger countries pose a much difficult issue, but we have been warning, the epidemiologists and the infectious disease community has been warning for the last 50 years that a pandemic is going to come and hit us very soon, and it has now. And there will be a new one very soon before we know it, so we need to have that in place. So my closing remarks about herd immunity, because that is the key topic of today's discussion, is the short answer to that is we do not know what the level of herd immunity required in Pakistan is. And again, as Dr. Asghar pointed out, that it's not the panacea of that we reach a number and then everything goes away. Herd immunity number is also a moving target. So if we calculate today that 80% of people to be immune is the level required to achieve herd immunity, that number will not, that number might change over a period of time, first of all. Secondly, even when we get to that number, the pandemic is not going to die immediately. There will be a tail effect, which will last for a certain number of days, weeks, or months, depending on the vulnerable population again. If we assume that the R naught for this virus, the new virus, the new strains is somewhere around 3 to 5, we need about 70 to 80% of the population to be immune to achieve that herd immunity level. So those are the theoretical answers. But again, in practicality, things are so much different, and there's so many more variables that go into calculating this and determining this. And again, having achieved that does not just turn a switch off overnight for pandemic to get over. There's still a tail effect that we need to manage by masking, by physical distancing, and perhaps even opening the windows, as you pointed out. Thank you.
Thank you.
There is no audio at all.
Hello, everyone. Thank you so much for joining us today. I think Amber was just asking for closing remarks, and we've already heard from Professor Adeel. So, Ma'am Aisha Raza Farooq, if you would like to finish off with your closing remarks on the situation in Pakistan.
Yeah, I think I'd just like to add here that, we've just seen firefighting when it comes to the COVID pandemic here and planning for vaccines here. I just hope that learning from the polio program, we can utilize build assets, build capacity within the country, whether it's manufacturing of vaccine or surveillance systems to detect any emerging public health issues in the future. I think we need to do that. I think we need to rely more and more, as has been said here, I'd like to reiterate that, on evidence-based scientific decision making that uses real-time data, so that, especially with the pandemic like COVID, where there are new variants emerging, the virulence is changing. We need to make decisions quickly. We cannot rely on our whims, and we need to rely on data to do so. So I would just like to see Pakistan moving forward, collecting more data, relying on more data, using evidence-based decision making and not our whims to do so. And I just hope that we can provide vaccine to the less privileged, and we can build more trust between vaccines and the caregivers, and use clear, consistent communication to build the right kind of fare out there for people to follow the required SOPs of protecting themselves from the COVID vaccine in coming days. Thank you.
Thank you so much, ma'am. So we're going to close this conversation. And again, we're really thankful for your time. I think that the conversation has made some very good points, and the consensus being that vaccination, yes, herd immunity, yes, but all of you are experts in this field, and the consensus is that we still need to follow the SOPs, which I think that for the average person who's watching this, I think that should be the main takeaway, that yes, we're going to wait for the vaccine, we're going to be hopeful. At the same time, we're going to make sure that we are doing everything we can in our power to stay safe. Thank you so much for your time, Dr. Asghar, Dr. Butt, Dr. Chaudhary, and Ma'am Aisha Raza Farooq. We will close this session right now. Allah Hafiz.
Thank you.
Thank you.
Thank you very much.
Thank you.